Hello friends, I am Dr Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. This is a vlog about gummy diabetic cataract. So we know that many times we get young patients who are diabetic, probably uncontrolled for some time, and they get this kind of cataract. This patient also has a shallow AC, and you can see it's a rosette kind of cataract, but there is no history of trauma, but there is a history of uncontrolled sugar level for some time. And additionally, there is a shallow anterior chamber. You can see a laser PI also done in the periphery just near the main incision, and I should have stained the anterior capsule, I feel here, because as I started the capsulexis, you can see the view is not very clear. So I was focusing hard so that I get a good capsulexis. In these cases, it's important in these cases that you should not be doing a very small, less than 4.5 millimeter capsulexis. That makes things much more difficult. I am using the Inamura forceps here. Hylucoat or Viscoat or Orocoat is the choice of OVD for me for doing capsulexis, which is combination of chondroitin and hyaluronate. So now I am going to release some viscoelastic from the anterior chamber there before I do hydrodissection. Again, for this soft gummy cataract, now you can see there was anterior shift of the nucleus indicating that the hydrodissection is complete. Good hydrodissection is very essential for these cases, because if you don't get the nucleus rotating well, sometimes you can land up in trouble. If you don't get a good hydrodissection at the beginning, you can do a trench and repeat hydrodissection, so you get a nice free floating or free moving or rotating nucleus. So here what I am going to do is try to do a half trench. It's a soft cataract, as you can see, and I am trying to chop it here. So the chop was successful, but you never get those clean, separated pieces in these cases, because that there is some stickiness in the peripheral cortex which kind of keeps these pieces stuck together a bit. So you never get that pleasure of nicely separated pieces. You always have some stickiness in that nucleus. Here I did a pretty good job because I got the first division right. So the first division is very important. If you get two heminuclei at the beginning which are nice and separate, then things become easier, and here I could further divide these pieces into smaller parts and could emulsify very easily. So that was overall good. But here, in case you are stuck with a bowl, then a bigger size capsulexis more than 5 millimeter really helps, as you can do hydro or visco dissection and pull out this soft nucleus up and then do emulsification. So here, all in all, it was quite good, but I think you got the idea how these gummy soft cataracts have to be divided and emulsified. So the first deep trench is very important. Here I did half trench and then chopped it into two halves, and again further divided into heminuclei. The cortex removal, I always use coaxial IA with the angle tip. The angle tip really helps for the subincisional cortex. As you can see, I can approach the fornix of the bag even in the subincisional area when I tilt the probe. So here the important thing is to make sure that the irrigation stays in the anterior chamber when you are removing the subincisional cortex. So these are few pieces of nuclei were stuck with the hylucoat there. So the idea is that the irrigation should stay in the anterior chamber as you rotate the IA probe towards the subincisional fornix area of the bag. This is a patient who wanted a toric IL because of the pre-existing astigmatism. So this is a toric IL going into the bag there. I am going to use the Callisto markerless system, so those 3 lines indicates the final position of the axis. So I rotate the IL in such a way that it remains few degrees, say 20 to 30 degrees anti-clockwise to the exact axis, so that once I remove the OVD from the anterior chamber and from the bag, I can then rotate the IL in its final position. With these kind of designs, it is easier to rotate the nucleus clockwise. That's why you can position it slightly in the anti-clockwise direction to the desired axis and then rotate it. But of course, even if it rotates further, you can gently nudge the IOL towards the center and then rotate it anti-clockwise. That's not an issue. So this is the final axis placement. All the OVD is out. I am going to hydrate the incision. Only outer half of the incision is hydrated, then the roof of the incision, and then before we finish, I will be giving moxifloxacin intracamerally. That's the end of the case. So for more such videos, do subscribe to my YouTube channel. Thank you.